There were a number of discussions held on the very frail population of amyloidosis patients that had either a BNP of over 8,500 or a systolic blood pressure of less than 90. These are patients who typically have a median survival of less than 6 months. The focus of the discussion in these patients actually revolved around whether these patients benefited from the implantation of cardiac devices such as defibrillator and pacemaker, as well as the use of a life vest. My opinion is that the majority of the investigators felt that there was no clear-cut proven benefit on the use of a defibrillator, that there were real difficulties in capture of a ventricular tachyarrhythmia or ventricular fibrillation in an amyloid-infiltrated myocardium. And as a consequence, there was not enthusiasm for the routine consideration of a cardiac device for patients with advanced cardiac amyloid. There was a major focus of discussion as to when to resume therapy in patients who have a hematologic response. And although it would be fair to say there really was not a consensus, everyone did feel that it was imperative that therapy be reinitiated before any new organ amyloid deposition was recognized. They were unable to establish specific light chain criteria in patients to say if the light chain were to rise to, for example, 20 or 30 milligrams per liter, that would be an indication for the resumption of therapy. But they all felt that careful monitoring of end organ function, liver, kidney, nerve, lung, heart, were all important, and that therapy was essential before any evidence of a rise in urinary protein, NT-proBNP, or alkaline phosphatase was recognized.